Good evening, Asha Murthy madam. She madam is from the Chennai.
Just now, ma'am, should we start with the welcome or how we go about, ma'am?
Yeah, first, madam, madam share her presentation.
Okay, ma'am.
Once it is seen on the
We
screen, then we will start it.
done, ma'am. Done.
Hello.
Yes, madam. Your presentation is visible. You can go for the presentation mode. Yeah. Welcome to all for the WINCARS first meeting on the nightmares in the cath lab. Actually, this idea has have wish happy new year to each and every person of the WINCARS and who are supporting the WINCARS. And this idea of this the nightmares in the cath lab actually has come from the Dr. Satish Sarita Rao, and she wants to conduct this, but this time she's busy, and so she informed me beforehand itself. So we are conducting from our side. So there are about three presentations. The first presentation is going to be by Gautami, and she's going to talk about mainly the no reflow phenomena. It is not a very new thing which we face in day in and day out in acute MI conditions during our angioplasties. No reflow phenomena we encounter very easily, but we will see how she was able to come over that condition. And the second one is actually just now Kavita rang up me at 6:30 that she has a case and she has gone for the case. Hopefully, she will join for the second or for a third case, and she is going to present a complication during performing the rota ablation. And the third one, if the time permits, Lalita will tell about a different minor coronary perforation to the massive coronary perforation and what it was done in those cases. But if the time permits, then Lalita will do it. Along with me, the moderator is Dr. Chebi Satpathy she is from the Chennai. Madam, may I ask your introduction by yourself because many new people has joined this time from the Assam and some other areas. So please, can you give your introduction, madam?
Yeah, thank you so much. Now, me, Dr. Chabbi Satpathy, am Associate Professor of the Department of Cardiology at SCB Medical College, Cuttack. Now, we have here 4+4, 2 units, and 4+8 DM students every year. And we are having only one cath lab. And very nice to have such a gathering. And so kudos to Madam Josna to having like a cementing effect of all the members around the country as well as international members also very much they are in tune with our madam. So I'm very much thankful to this body. So we should go quickly to the presentation.
Thank you very much, madam, talking nicely about all the WINCARS members. So may I request Dr. Gautami to go ahead?
Yes, ma'am. Good evening, one and all. Today, I would be speaking about a case which have complication which happens quite frequently in the cath lab. So, coming to the clinical history, this is a patient who is a 68-year-old female presented with angina to a tertiary center. She was diagnosed there with help of ECG and troponins as anterior wall MI. As she was out of window period, she was not thrombolized there, and she was shifted to our center because of the high yields that was given, and she was shifted in Phillips class 3. Echo showed RWMA in LAD territory, and it was akinetic anterior wall with aneurysmal LV apex. Mainly, it was aneurysmal. And angio was done on day 6 after stabilization of the patient, and it showed single vessel disease with LAD 99% occlusion with almost TIMI 1 flow. And the viability study was done subsequently, which showed 84% viability in LAD territory. So we proceeded ahead with PTCA with a plan of 2 stents to LAD. And this is the perfusion scan showing, and it was a severe LV dysfunction. I have first projected only the
Can
still
I
images.
interrupt Gautami here to ask the other people, is that is required really to do the viability test in an acute MI of the 7 days duration? Whatever the other people will think? Dr. Shabi madam?
Will you Can you repeat the question?
At the 7th day of the MI, do we do the viability even in the severe LV dysfunction following an MI?
Yeah, normally, ideally, we should go within 48 hours. If it's a primary PCA, it's all right. We normally post within 2 days. Otherwise, those who are having still angina or variable ischemic changes, they may go for that.
My opinion actually is about it is a relatively stabilized acute coronary syndrome, and viability usually will persist for 3 weeks. So unless the patient's presentation, subsequent presentations is in a heart failure, and especially if the patient has an angina, that itself says that there is a viable myocardium. So
Yeah.
I think I may not insist on going for the viability in this condition. Yeah,
Because
please
here
go ahead.
LV was already aneurysmal, apex with severe LV dysfunction. So we thought of doing the viability study and proceeding ahead with PTCA.
Yeah, excellent point. That is correct.
Yeah.
When the
Yeah, because the
aneurysmal
patient is not
dilatation is there, even
Yeah.
in the aneurysm, if you do the PET scan, nearly 55% of the cases, you demonstrate the presence of the viability within aneurysm. But once aneurysm is there, yes, as you said, it is correct. We should see the viability.
How much exactly is the LV size, Dr. Gautami?
Ma'am, it was around 5.7, 5.6 around. It was mildly dilated.
Mildly dilated
Yeah.
with severe dysfunction and the sun
Apex was more aneurysmal, madam.
And the patient is not having mode of angina or changing in the STT changes. These are not there. So you have to do a viability study, right?
Yes, ma'am. Can I proceed, ma'am?
Yeah, you can proceed.
Yes. And these are the angio-still images of the patient showing the elevocaudal view. I will be presenting the videos later. So this is an elevocaudal view showing middle lady almost 99% occlusion. This is the areocranial view with the tight lesion with TIMI 1 flow, poor distal filling. And so we the procedure in steps, we have first wired the branch also as it is significant size, and wire was put into the distal LAD, and then we have done balloon dilatation with 1.5 12 mm small semi-compliant balloon, following which there was TIMI 3 flow after balloon dilatation, and we have chosen 2.75 into 13 mm stent, and we proceeded ahead with stenting directly.
Gautami, I think it is worth showing the video because it is looking like a double LAD versus a dual LAD. So we can think about it actually. Why don't you have any video once?
Yes.
Anyone has any idea when to say is a dual LAD or a double LAD? They're not playing, just they played once and they stopped. Can you put it in a continuous cine mode? Yeah, good. And one cranial view.
So this is a elevocaudal view showing poor distal filling, and this is epicranial.
Yeah, actually,
This is after balloon dilatation with 1.5 into 12 mm balloon. So reasonably good amount of
this LED actually, if you see, can you play that once again? It is looking like a dual LED. because it is mainly the one of the which is come the medially, that is a septal, but that LED is giving the septal branches. Whereas the other LED which is going to the lateral aspect, that is giving the diagonals. So instead of nomenclature, of course, nomenclature varies differently, but it may be the worth revising once again the nomenclatures in this type, because it's other people can say it is a very large diagonal, but for a nomenclature sake, it is a dual LED.
Gautami, is the other artery reaching your apex?
No, ma'am.
One
It is not reaching the apex.
Are there any large diagonal apart from this one, or this is a LED with small diagonals?
The one in which is wired till the distal, that is the LED which is reaching the apex, ma'am.
One which is bigger is having no septals, right?
It is
And
the one which is bigger
smaller
is having septal branches, but it is not reaching the apex. The one with the poor distal filling flow which was seen is the one which is reaching apex, but it is thin in caliber till the in the distal part, ma'am. If you can see
the
the
lower
one.
one. You
which
mean
is
the
wired.
lower one?
Yes,
In
ma'am.
this picture, the lower one is with septal, right? Is with perforatus. So that has to be LED, and the other one most likely is a second LED, because this is not giving any diagonal, and the other one appears to be reaching at the apex.
Yes, ma'am.
So could be a dual LED. Could be a dual LED.
Yeah, the diagonal branches are coming from the second
Upper
LED.
one.
Yeah,
Upper branch.
those smaller, they seems to be diagonal.
And actually, the two people sent a message that for a pain-free patient, we do the viability. They wanted to do the viability when there is no angina, so to confirm that. And of course, Monica asked what is the thickness of an LV and 2D account. Already Dr. Chabi asked and you answered about it. Yeah, please go ahead.
So this was post balloon dilatation. We can see reasonably good amount of flow. And this is after stenting, ma'am. So immediately after stenting, what happened was we saw there was the flow has reduced. After ballooning, the flow has improved, and after stenting, it has reduced. It has come down to TIMI 1 flow. This is post stenting to 2.75 into 13 mm, and the patient went into cardiac arrest. So she became unconscious, and as soon as the flow has diminished, she became unconscious. She went into almost arrest, brady, followed by almost arrest. Then we immediately placed a venous sheath and placed her on IABP and stabilized her. We have passed a microcatheter into the distal well. First, we did a balloon daughtering with a small balloon, 1.5 into 10 mm balloon. Little flow was established, and after following that, we have given intracoronary tyrofluban, bolus dose, followed by intracoronary nitroglycerin. After that, her heart rate became again normal, and she was stabilized. She was shifted to ICCU on IABP. This was the final shot. So her flow has improved. She was shifted to ICCU, and then she was put on IABP for 2 days. After that, patient has improved, and she was discharged after 6 days in stable condition, and she came back after 15 days for the first follow-up also, and she's totally asymptomatic now. She's not having any dyspnea or angina.
So what do you think why it has happened on the day 6 of the NMI? Usually we see the no reflow phenomena very frequently in the primary in angioplasties.
Yes,
what is the cause? When the balloon dilatation is done, there is no distal embolization, no reflow phenomena. When you are positioning the stunt, it is not happened. But after the stunt deployment, it is happened.
Yes, ma'am. Actually, no reflow, it occurs either after thrombolysis, so reperfusion no reflow phenomenon, or interventional no reflow phenomenon, which occurs frequently at the time of intervention. So probably there is still thrombotic burden in the lesion, and after stenting, it might have embolized distally and might have caused the no reflow phenomenon. Initially, we dilated with a small balloon, madam, 1.5 into 12 mm balloon. For that, there was not much significance. But once it was stented, immediately we observed decrease in flow. So probably we thought it would be because of no reflow only, and so we tried to pass the microcatheter into the distal bed and deliver the drugs there. And patient has improved to a reasonably good extent. She almost was arrested, and after delivering the drugs and putting her on IABP, she became conscious within few minutes, and her vitals were improved, stabilized.
Dr. Can I ask just one question? It's not very clear where exactly the stent has been deployed.
Here, this was the site of the lesion.
That is distal to the one giving septal perforators, the proximal end?
Yes, ma'am. Approximately after giving septal perforators, there was a 99% occlusion.
Okay.
I
Okay.
can just
You can
go
show the
back and
first
show you
angio.
areocranial view, ma'am. Just a minute. The angio. Yes, ma'am. This was the site of the lesion, and this is the picture after balloon dilatation.
Okay. So the stent was just beyond the artery which is giving rise to the septal perforators, right?
Yes, ma'am.
And was there any obvious thrombus prior to your implantation of the stent?
Pardon, ma'am, I could not hear you.
Any obvious thrombus there prior to implantation of the stent?
No, ma'am.
No, it was not seen. And before implantation of the stent, how many dilatation were needed?
Only single dilatation with a 1.5 into 12 mm balloon.
Yeah.
As soon as the flow was established, we did not do subsequent dilatations. We directly proceeded ahead with stenting, ma'am.
Okay. You can proceed.
One more thing is, if it is really a thrombus distal embolization is responsible for the no reflow phenomena, just by daughtering of the balloon and giving the vasodilators in through the microcatheter distally doesn't open up the vessel so well. So I think it is maybe a
Could be
vasospasm component
vasospasm.
maybe also there in this condition, which is a super added to this, because we are not seeing the obvious thrombus there. All said and done, even though it is angiocordographically, we are not seeing. Of course, OCT is a better option to really to see that whether thrombus is there or not. But the way the patient is almost arrested and revived by passing the balloon, uh, it just says that sometimes for a very significant vasospasms, actually balloon dilatation will work, but here just you pass the balloon but still it is able to establish the flow. And one person asked, is there any edge dissection, will increased LVDP contribute to the slow flow?
But it should not be there after stenting, ma'am, because if at all that could have been the reason, it should have been there even after balloon dilatation. It was not evident after balloon dilatation. The no
Yes,
reflow was observed clearly after stenting.
yeah, this edge dissection is angiocordographically, of course, what you are shown it after the final this thing is not much demonstrating any edge problem. So I don't think the edge dissection is contributing. And even in the edge dissection, unless you do the plastering by the ballooning at that area, which is producing a slow flow or no flow previously, can't be reverted back spontaneously to the normal. So probably edge dissection is unlikely. As the madam suggested, I think increased LVDP can contribute to the slow flow. Yes, definitely. The blood flow of the coronary is mainly the trans coronary gradient, which will cause the perfusion of the coronaries. When there is an LVDP is raised, and even the small episode of the hypotension during the balloon inflation, I can decrease the a significant coronary gradient comes down, so the blood flow will come down. But those are spontaneously then improves by itself without doing anything. But here you have to do the daughtering and giving then all the vasodilators distal to the bed and all those things. Says that probably this may be not be the reason for raised LVDP.
Probably it could have been vasospasm, madam, as you said. It could be because it has improved very well with NTG and tirofiban doses also after they were delivered to the distal bed. So that's with the case, ma'am.
Please go ahead. You wanted to say something else?
Yes, ma'am. Just to add few points on no reflow, it is defined as inadequate myocardial perfusion through a given segment of the circulation without evidence of any angiographic evidence of any mechanical vessel obstruction. So principally, it is when you see a flow, TIMI flow less than 3 or a TIMI flow of 3 with myocardial blush less than 2. So both of this, it is considered as no reflow. Most of the times it is TIMI flow less than 3 only. So you have two types of no reflow phenomenon, the reperfusion one, which is seen after thrombolysis, and the interventional one, just as in our case here. So reperfusion, the patient usually will be asymptomatic and he may be asymptomatic, but most of the times it is evident by increased persistent ST elevations in the ECG even after thrombolysis. And interventional no reflow, it is usually during the procedure, and this has better prognosis than the thrombolytic perfusion no reflow. So it is again classified into sustained no reflow and reversible no reflow. Sustained is the one when you have, it is because of the anatomical irreversible changes in the coronary microcirculation, like the pre-existing microvascular dysfunction, which is seen in some patients. They are more prone to have this no reflow phenomenon. The reversible no reflow is the result of functional changes, just as the vasospasm and embolization, which it is a reversible changes of the microcirculation. So the no reflow is reversible because of the functional changes. And these are the four principal causes of the no reflow phenomenon: the distal embolization and the ischemic injury, reperfusion injury, and the individual susceptibility, which is the tendency of the microvasculature to go into no reflow phenomenon. So what are the predictors are distal embolization? It usually depends upon the thrombus burden of the lesion. And the ischemia component, it depends upon the extent and duration of the ischemia. And reperfusion injury is because mostly of the endothelial intrusions into the vessel lumen, and also the neutrophil and platelet entrapment into the vessel, myocardial cell edema, which causes the compression of the microvasculature because of the reperfusion injury. So this is the principal cause. And individual susceptibility of the microvasculature to no reflow phenomenon is because of the diabetes and uncontrolled sugars and hyperdyslipidemia, which happens. So there are several techniques by which we can diagnose the no reflow phenomenon. The conventional 12-lead ECG, it shows persistent ST elevation, non-resolution of the ST segment elevation, and coronary angio, we can see the TIMI flow, which is less than grade 3. And the myocardial contrast echo also, absence of opacification of the myocardium in the myocardial contrast echo. And obviously we can show in the magnetic MRI and PET scans also the no reflow phenomenon can be seen. And this is we need to treat the no reflow phenomenon based on the pathophysiology. So for distal embolization, it's better to use the TP2B3A inhibitors. Tirofiban has worked well in this case for us, and also the vasodilators, adenosine and the nitroprusside. And for the reperfusion injury, it is better to go ahead with verapamil, nicorandil, and also additively adenosine and nitroprusside. So we need to actually prepare the patient well. So if you suspect patient has uncontrolled sugars, you better control the sugars and then take the patient on table. So these are the important things. So this is the main important point. We need to plan the case well, and then we have to maximum see that we prevent this no reflow phenomenon, because it is difficult to manage once it occurs. That's all.
Yeah, one of the doctors suggested giving a nitroprusside, SNP. I think it is a nitroprusside, what they meant it.
We give it very rarely, ma'am. We usually go with adenosine, verapamil. So what is the difference? Which is the best drug, ma'am? Actually, I wanted to ask. So, is it NTG adenosine sufficient, or do we need to go ahead with verapamil, nitroprusside? What is the sequence of usually? How should we proceed with this?
I don't think there is a single drug for this condition. You have to see for the combination of the drugs, usually the works. And SNP is really the good. It is works. We used to give it SNP much more frequently. Nowadays, we are not getting the nitroprusside. Actually,
Yeah, it's not.
yeah. If you are giving intracoronary with the microcatheter, then you need not much worry about the hypotension. Most frequently, it doesn't produces the hypotension unless your doses increases more than 200 micrograms. So then it is known to have the systemic effects. So safely you can give a normal doses of the all the vasodilators intracoronary, even in the hypotension condition, nothing will happen.
Okay.
But there are many people who give the neosynephrine, the bolus doses of the epinephrine and adrenaline, and increase the systemic pressures and give the intracoronary vasodilatation. That is also is well accepted to maintain the systemic pressure by the inotrope, but give the vasodilatation into the intracoronary through the microcatheter. That also helps.
Okay.
Yes, but I don't think exactly the sequential or series mentioned you give this followed by this. Out of this, I think any one of the option you can choose. There's nothing specific. You have to give this one first, followed by, if not effective, then this one. Nowhere it is mentioned like that.
Okay.
So that was a very nice presentation. So just madam, do we have to ask any question, or we are going to the second case?
Yes, madam. We are going to the second case.
Okay.
Dr. Kavita is ready. Dr. Kavita is working in the Delhi now, and previously also she presented very quite interesting cases in our previous meets. I will request now Kavita to present her case. I'm not able to hear the Kavita's voice.
Am I audible?
Yes, yes, you are now audible and visible.
Okay, good evening, ma'am, and good evening, everyone. So we have this patient, 80 years old lady. She had recent antiviral MI. She came to us in October during the lockdown period, and angiography was done outside, and she was advised CABG. She was diabetic, long-standing, hypertensive, obese, COPD, and EF was reduced to 35%, and was also some CKD element. So she came to us on 30th, maybe late afternoon, and her BP was just borderline, her saturation, everything was just borderline. So first we took her to Cath lab and we put IBP, and then we spoke to relatives about the condition. So relatives were clearly know about CABG. We also had seen the CD, so clearly it was a case for CABG. But relatives said that at this age of 80, do whatever if you can or if you want, otherwise we will not do anything. So then we yes. IBP had put 1 day prior, and then on 31st October, we took this patient from the planning of doing something to LED. So this was the left side shot, and we straight away took EBU 3.57 French. And this was TPI we put initially. We had seen the calcium and everything, so we thought of doing rota, and we thought of doing plastic to it. So we put TPI, and this is the left side. So clearly we are seeing LED, totally calcified, totally diffusely diseased vessel, and LCX is also not very great, but that's what it is.
Kavita, do you think with the ejection fraction of 35, so much of calcific vessels with a complex lesion, extensive one, do you think that IBP will do for it, or you will go for a higher like an Impella?
Yeah, ma'am, we could have, rather we should have gone, in fact, but then financial and all those things, finances were huge constraints. So IBP was only possible for us. But definitely we should have chosen, LVAD would have been definitely a better choice for this patient, if permits. So then this is angio. And so initially we tried with our usual workhorse wires, which didn't go. Then we somehow crossed the lesion with all star long wire 300 centimeter. And then we exchanged, we took fine cross 3F microcatheter. And through the help of that, we finally could take rota guide wire to the distal LED. And then we took rota burr 1.5. So this is the beginning of rota. And somehow we could negotiate it through with lots of palpitations for us. So it was rota link plus 1.5, and we did whatever. So 3-4 runs we did, and then we came back.
Is this the floppy or extra support?
Then this was extra support.
Okay. The one thing I want to comment is in the first angio, almost the rota wire is turning the apex, but usually rota wires so distally better not to put it. We have to concentrate on where we are going to do the rota, and just a little bit of distal to that is much better because we know the stiffness of the rota wire.
Yes, ma'am. So then this rota floppy wire was taken out again with the help of fine cross 3 French, and whisper extra support guide wire was taken to distal LED. So this is whisper extra support wire. And then before taking the rota, once we tried IVUS actually in the beginning only just to see, but initially our IVUS catheter did not go. So after rota, we again took IVUS catheter, and this IVUS catheter we could negotiate through, and then we could do IVUS. So this is the IVUS run, IVUS HD we took, because taking OCT was not an option, a good option with this patient. And IVUS HD was fortunately available to us. So we saw the entire artery. It's a long length catheter, and the visibility is also very good. So we could see from the distal itself, very narrow lumen and lots of chunk of calcium we will be seeing. However, there was no thrombus in the entire artery. So we are seeing here lots of calcium, and we'll be seeing same thing in this. So almost 180 degree, 360, and this is the reverberation of calcium, and almost a ring then again. So the entire LED mid onwards to proximal was calcified, and lumen also of the entire artery was very diseased. So this was the IVUS run after rota. So we really do not know how much rota has done, because lots of calcium we are still seeing. And this is now again very narrow part, proximal LED. total ring of calcium. So in rotablation also, it is known that the complete calcium ring, it might not penetrate because of the wire biasing at all. So after rotablation, we,
I
with
think
the help of this IVUS, we got a clear picture of what it is. Yes, ma'am, you had wanted to say something?
Yeah, actually, the IVUS after the rota has a two purposes. As you are already tried in the beginning, which you was not able to negotiate, and subsequently you are able to. The first thing is to know the efficiency of the rota, like how much it is the calcium which is present, which is able to break it.
Yes, ma'am.
Many of the areas we are able to see that it is not able to break it. Still, the significant calcium arcs are continuing. So at this stage, the rota helped us in saying that it is not an effective rotablation.
Not an
Up
effective
until the
rotablation.
extent it is not an effective rotablation.
Yes,
So
ma'am.
it gives the option of either going to the higher size rota or some other than the rota, like nowadays we can think of an IVL, maybe they required, or high pressure balloon dilatations are required before taking a stent implantation in this condition.
Yes, ma'am. Yes, ma'am. These are the still shots. This is proximal segment showing entire calcium ring. And this is the mid segment, almost entire ring of calcium. And this is also a ring. So these were the few rings still left to us. And these are the just images of calcium reverberations. So when we could not dare to take a higher rota bar actually than for this case. And so we tried cutting balloon. And this OPNNC also somehow we could not dare because we were seeing that so fragile, so frail, everything. So maybe we can rupture or perforate that. We were actually scared to use any other thing. So, but we took cutting balloon, and cutting balloon also did fairly good job. I'll show you in the subsequent IVUS view. So this is cutting balloon we did, and then these are the runs again after cutting balloon. So we will see that lots of those calcium rings, they have been broken actually very effectively. So I'll show you the still images. So this is the post-rota cutting balloon, and these are the rings, these are the broken things from this segment. This run also I can. In fact, all the rings were broken to some extent. But then breaking of this calcium ring, I think leads to spicules of calcium, which are haphazard and they are also equally dangerous. This is what we learned in this case actually. So demonstrating this breakage, but I don't know this calcium is, I don't know in which direction it is cutting and what it can lead to further. It will be, sometimes it can be very dangerous. So that's what we were thinking about after this case, that we were happy that this cutting balloon has done our job possibly. I think in this case, IVL balloon would have been a definitely ideal choice, which just, so, and we had this dissection out also in this part of artery. And small perforation was also seen in this run. But then otherwise patient was hemodynamically good so far. And so we thought of taking stent now. I don't know whether I should have gone further for dilatation or what. Panel has to say something. But we could do only this much once we saw that calcium ring is being broken and
No, I was not certain about that perforation, what you said it. Can you show that Area once again and demonstrated.
It is not, it could be just dissection only, I think, because for calling it perforation, it has to come out of the vessel wall. So maybe just, but this dissection was there certainly. And here we are not seeing any much calcium also. So, but dissection we created.
No, when you have the doubt about the perforation versus the dissection, the one more method is to put a balloon at that area and then try to inject and see it. If it is a flaps or anything, that will be lifted off and you will have the flows. So when you have a doubt about the perforation, directly going for the stunt, is that acceptable?
Actually, angiographically, there was nothing extra seen. So,
Okay.
so that made us to proceed for deploying a stent. So this is the first stent we took, 3 into 38. We deployed it, but we are seeing certainly calcium outside. But this is the distal part is nicely deployed, but proximal is still.
This stunt went easily, or you had any difficulties? So much of calcium and all.
It went. With negotiation, it went because we didn't need any extra support. We didn't need guidezilla or anything. It went. And then we took another stent that was 3.5 into 28 from ostium to distal, overlapping this one, and we deployed it. So, but we are seeing clearly that it is not the. Then we did post dilatation of the entire stent, first with 3.5 into 12 NC, and then actually we took 3.5 into 15 also, one more balloon. And after that, ostium part was not very nicely dilated. So we thought that maybe.
What was the size of the proximal LAD on IUS?
It was 3.51.
Then why you are oversized to the 4?
Angiographically, I think that view is not there. I think. So this was this stent, and so ostium part we thought of dilating with 4 into 15. And after that we saw this. So yes, ma'am, as ma'am is saying rightly, maybe dilatation with 4 balloon did it, because spicules and those broken calcium was already there. Maybe it lead to that. Or maybe that dissection was also there in the proximal part, so that got extended. So this was the perforation. So then we took Apollo NC 3.5 into 12 millimeter, and we dilated it, in fact, 5-6 times for 30 seconds each. And after prolonged inflation, this seemed to stop. So this was the final cine we could get for that day. That was the last shot for 31st October evening. And the patient was okay hemodynamically. She was anyway on the IBP and TPI, though her own rhythm, saturation was okay, and she was not tachycardic or tachypneic.
It's a proximal perforation, so not much of pericardial collection.
Ma'am, till now, there is no pericardial collection, and the patient is hemodynamically stable. We have done the echo also, and echo there was nothing seen by now. And angiographically also, as we are seeing, that that thing has closed. The perforation part is not seen here. And now you can see that this ostial part of the stent is still so tempting that we should dilate it, we should make it a little more. But that mistake we already done. So now finally at this stage, we shifted the patient back to CCU. No, we did the IVUS also. I think after this also we did one more IVUS to see whether that perforation or whatever it is has healed or not. So we saw the different, proximally also we could achieve 7.48 millimeter square area, and some stent malposition was there, but we did not dare to do anything for that because we had already done perforation and everything. And this middle part also we were able to achieve area of 7.82. And so almost area was satisfactorily achieved. And distal part also we had maximum of 6.32 millimeter square area. So with this, with these last IVUS findings, that we achieved a reasonably area almost everywhere in the entire vessel, and there is no clear-cut perforation seen now. There is no clear-cut leak seen now. We shifted the patient out of cath lab, apparently in hemodynamically normal, stable condition. And overnight patient was okay, but the next day morning again she was unstable hemodynamically. So we did urgent echo and we saw the large pericardial effusion. So we shifted her immediately to cath lab. And again, same perforation we are seeing here. So now we had no option because we had tried prolonged inflation, therefore. So we took graft master 3.5 into 16 and we post dilated this graft master with the Apollo NC 4 into 10 millimeter again. So it was, we put this wire and balloon in the circ because circ was already hazy. And we thought if we shift something to circ or if we happen to close circ also, at least we can do.
Yeah, Dr. Kavita, am I audible?
Yes,
Am
ma'am.
I audible?
Yes, ma'am, you are audible.
My question is patient of 80 years old with severe calcification. The stent seems to be underexpanded. Is it a better case for bypass?
Ma'am, bypass was already discussed. She was shifted from outside hospital. Their bypass was suggested. We also suggested bypass only. It was lockdown period in the month of October. And she was 80 years with almost possible comorbidities. So attendants said that if you want to do or if you can do anything, you do. Otherwise, we are going to take the patient home.
Normally, do we go for a rota ablation when the arc of calcium is around 300-360 degrees?
Ma'am, initially we can start because at least at whichever level it can break, it should, and then we can use the balloons, induced balloon, because rota is the beginner of the calcium breaking, basically our entire therapy, and then we can use our OPNC balloons or
because no other options are left for that. We have gone, but I think no, it's not indicated for rota. What's your opinion about it? Is it indicated for rota?
Ma'am, but without rota, I think we were not able to do anything in this artery because initially we tried to see inside what is happening, but we could not pass our IVUS. And other balloons, that seemed very impractical to use balloons that time without using the rota in this vessel.
Yeah, because we don't have any option, so you have got patient has got a good result. Okay.
And then this is the graft master we used, and then we did post dilatation, and so then this is the final result of this. And then we did pericardiocentesis. Then after pericardiocentesis on TPI and on IBP and on pigtail in pericardium, we shifted the patient out again, and then patient was stable after that. So we could send patient home.
Now, once you saw perforation, Kavita, and the clear-cut pericardial effusion, do we reverse the anticoagulation? What is the present recommendation? Some say yes, you have to reverse. Some say once a stent is given, you should not reverse. So what is the final opinion?
Ma'am, actually, this was the proximal perforation, and we had graft. So, and reversing the heparin in this elderly lady, we do not know how consequences, whether she will have a stroke, whether she will have some thrombotic phenomena, especially during those COVID timings. So reversing,
Yeah,
reversing the
yeah,
event, we did not think of. There didn't seem to be a safe strategy.
yeah.
Right?
And the stent may again be blocked. You have given a stent's difficulties, and again it may be blocked once you are reversing. So it's
Yes,
a
ma'am.
double-edged sword. It's a double-edged sword. There's a large pericardial effusion, and you have given a stent, patient 80 years old. So don't take one hand.
Yes, ma'am.
Yeah, in this case, definitely we will also go ahead with an rotablation. Otherwise, it is not possible to do it at all. And direct, even for the IVL, if it is available and patient can afford also, the problem comes is the negotiability of the balloon.
Yes,
So,
ma'am. We have to have some space there. Yes, ma'am.
so you should have the rota in this. There is no doubt about it. But finally, what I would have been done is because already deceased circumflex is there, and you kept the balloon or stent. You should
We kept balloon.
actually taking a stunt into that and treating that condition would have been a much better option. It's fortunate that nothing has happened to the circ now because that is a graft master and occlusion of the circumflex becomes a problem. So the better is to deploy the circ stunt also simultaneously along with the graft master, so that you will have the patency of the both, and of course you will have the treatment for the tighter lesion of the circ.
Yes, ma'am. I think yes, we should have done that. We should have stented the circ. But I think we were not sure about the calcium part of it, so we thought that rather than leaving one more under deployed stent in circ, so let it flow.
Yeah.
Here the size of the vessel was only 3.5, but you had dilated it with a 4 NC.
Ma'am, I think because of lots of calcium and it may be undersized looks, because it all went well after that. It looks actually normal size because either it had aneurysmal segment, ectatic segment distally, because stent also, this stent didn't look properly deployed when we initially tried to do it with the 4 balloon. That time the stent was looking under deployed at the point of ostium in comparison to the rest of it. So that's what made us to think that maybe we should make ostium a little more flary.
I think we should rely upon IVers when we had done the IVers. And what you're
Yeah.
saying is correct, madam. If you come to the left main and then you wanted to dilate to corresponding to the size of the left main, would have been a proper one. I think it's definitely slightly oversized balloon, but is managed very well, and fortunate that the patient doesn't have much branches there to occlude, or otherwise, lady most of the time one or two, one septal or one diagonal is almost will come. So the patient doesn't have then anything to be closed at the time. That's good. Excellent, excellent case.
Yeah. Initially it was looking underexpanded, but now it's looking better.
Yeah.
Now it has 2 stands basically, that initial the giants and the graph.
Yeah.
So it's very big size. So ma'am, I think this was a very nice experience with HD catheter of IVS. The images were almost as good as OCT images. So I just wanted to share 1 or 2 slides of HD catheter, which we have for us available. So it is very nicely, we can see dissection, false lumens and thrombus, this case, OptiCross HD 60 megahertz imaging catheter. And this is the comparison slide. This is OptiCross HD, Boston Scientific, and this is 40 megahertz, this is 60 megahertz. So the axial resolution, the lateral resolution, and soft tissue penetration, in fact, the blood penetration, the guide compatibility, everything is very nice and very nice to handle this catheter actually. So we can always keep it and use it for the people in whom OCT is difficult. So the image quality, other than color, if you leave the colors, but we can, if we train our eyes, almost we can see very nice images. So that's I had wanted to share with everybody. This one catheter which is use worthy. Thank you, ma'am. Thank you so much.
Yeah, very risky and nice case.
Yeah, I think we will withhold the other one because now it is already 1 hour is over, and the next Lalita case is also is a perforation. What do you feel, Lalita? Can we wind up?
Yes, ma'am, definitely we can.
Yeah. And really, I'm thankful to all the people who joined and who commented, gave their opinions. at the different levels. And this is the first WINCARS meet we are starting. And actually, we are trying to get the even credit points also, credit our points also for our discussions and the presentations. I wanted the more active participation for each and everyone. And the next time we are going to have the webinar from the Andhra Pradesh people on the 12th. Please join for that. And followed by the Assam and Arunachal Pradesh are doing the clinical cardiology meet and interventional cardiology meet. And our main aim is to include each and every person from each and every corner of India. So actually, personally, I'm calling them and trying to contact them. So the people who are the present for this meeting, please convey the message to the other people so that more people will come. We will have the more better ideas than what we think with a tubular vision. Dr. Shabi, you wanted to say anything?
Yeah, ma'am, it's a very nice initiation and the cases are very interesting also. We have to learn from each other. Now, many times we are in a dilemma what to do, whether to do or not, but finally the patient has got the good result. That is okay. The patient is discharged. I don't know what about the follow-up and what the patient did thereafter, but it appears to be very nice, both the cases. So thanks to both the presenter.
Thank you all, and thank you to this Torrent who helping us continuously in conducting these meetings. And I'm very thankful to Dr. Abdul and Dr. Rahul. Rahul is an excellent person who does many things. And through the Abdul, we are able to the work. And I'm thankful to the company people also. Thank you all.
Thanks to you, ma'am, and thank you, everyone. And ma'am, our support for this initiative will always be there, ma'am. Our platform is always available for you. Thank you for this.
Thank you. Thank you all.
Thank
Bye.
you. Thank you, ma'am. Thank you all.
Thank you. Good night.
Good night.